Now and then, all of us feel, think, or act in ways that resemble a psychological disturbance. We get anxious, depressed, withdrawn, or suspicious, just less intensely and more briefly. So it's no wonder that we sometimes see ourselves in the psychological disorder we study. To study abnormal is the best way to understand the normal, said Williams James. And so during this lesson, we are going to be talking a little bit of an introduction into psychological disorders, and then we'll be talking a bit about the anxiety disorders. So hopefully in the course of this lesson, we can learn the following. What is the difference between normal behavior and a psychological disorder? How and why are psychological disorders labeled, and why do some criticize the use of diagnostic labels? What are the main anxiety disorders, and how do anxiety disorders differ from the ordinary worries and fears we experience? And how do learning and biology contribute to the feelings and thoughts found in anxiety disorders, OCD, and PTSD? Okay, so first let's talk about what a psychological disorder is. A psychological disorder is a significant disturbance in an individual's cognitions, emotion regulation, or behavior. Disturbed or dysfunctional thoughts, emotion, or behaviors interfere with the normal day-to-day life. And so this is also includes, oftentimes we use what's called maladaptive behaviors. And these are behaviors that are performed to help us relieve our anxiety. So an intense fear of spiders may be abnormal, but if it doesn't really interfere with your life, it is not a disorder. Believing that your home must be thoroughly cleaned every weekend is not a disorder. But when cleaning rituals interfere with work and leisure, they may be signs of a disorder. An occasional sad mood that persists and becomes disabling may also be a signal of a psychological disorder. Okay, so let's talk a little bit about the history behind disorders. The way we view a problem influences how we try to solve it. In earlier times, people often thought that strange behaviors were evidence that strange forces were at work. Had you lived during the Middle Ages, you might have said the devil made him do it. To try to drive out the demons, mad people were sometimes caged or given therapies such as beatings, genital mutilation, removal of teeth or lengths of intestines, or even transfusions of animal blood. So we have reformers such as Phillipe Pinel. So he lived in France, and he opposed really these horrible, brutal treatments. Madness is not demon possession, he insisted, but a sickness of the mind caused by severe stress and inhumane conditions. So curing the sickness requires moral treatment, including boosting a patient's morale by unchaining them, talking with them. So he and others would work to replace the brutality with gentleness. Also, isolation with activity, and the filth with clean air and sunshine. So also one of the things that Pinel did is they had, and sometimes in the hospitals they would sponsor patient dances. They were called lunatic balls, to try to get the patients socializing. Okay, by the 1800s, a medical breakthrough prompted further reform. Researchers discovered that syphilis, which is a sexually transmitted infection, invades the brain and distorts the mind. This discovery triggered an exciting search for physical causes of other mental disorders and for treatments that would cure them. So hospitals replaced madhouses, and the medical model of mental disorders was born. So this model reflected in words that we still use today. So we speak of the mental health movement. A mental illness needs to be diagnosed on basis of its symptoms. It needs to be cured through therapy, and which may include treatment in a psychiatric hospital. Recent discoveries that abnormal brain structures and biochemistry contribute to some of these disorders had really also energized this medical perspective. So the medical model is the whole idea that this concept that psychological disorders have physical causes. They can be diagnosed and treated because we think of them as an illness, and in most cases they actually can be cured. So the biopsychological approach, and the biological, psychological, and sociocultural influences combine to produce psychological disorders. This broad perspective stresses that our well-being is affected by the interaction of many forces, including our genes, our brain functioning, inner thoughts and feelings, and the influences of our social and cultural environment. So it's right there in the word. It's biology, psycho, which means like the brain, cognitive thinking, sociological, which helps us think about like the social, cultural aspect. All these things combined create and affect our environment, and everything affect our psychological well-being or even psychological disorders. So, why do clinicians classify disorders? In psychiatry and psychology, classification will tell us a great deal. To classify a disorder such as schizophrenia implies that a person speaks in a disorganized way. They have bizarre beliefs, shows either little emotion or inappropriate emotion, or is socially withdrawn. Schizophrenia is a quick way of describing a complex set of behaviors. But diagnostic classification does more than give us a thumbnail sketch of a person's disordered behavior. In psychiatry and psychology, classification attempts to predict the disorder's future course and suggest the treatment. And it prompts also research into causes. And also study a disorder. We must first name it and describe it, so it's a really important part of it being an illness. You need to classify it and describe it. So it gives us why we study and we diagnose psychological disorders and classify them. It gives us a possible explanation for a person's disordered behavior. It helps us predict the disorder's future, allows us to suggest possible treatments to the disorder. The most common tool for describing disorders and estimating how often they occur is the American Psychiatric Association's 2013 Diagnostic and Statistical Manual of Mental Disorders. Now it's in its 5th edition now. Many examples have been drawn from this whole class that we are studying. Physicians and mental health workers use this detailed diagnostic criteria and codes in the DSM-5 to guide medical diagnosis and to define who's eligible for treatments, including medication and corresponding insurance coverage. Okay, in this new edition, we have had 5 editions. Some diagnostic labels have been changed. The conditions formerly called autism and Asperger's syndrome have now been combined under the label of autism spectrum disorder. Mental retardation has become intellectual disability, and there's also new categories including hoarding disorder and binge eating disorder that have been added to this. So basically the DSM-5 is really the criteria to classify psychological disorders. It is the manual that health professionals and psychiatric professionals use to help diagnose and to treat disorders. Okay, so anxiety. Let's talk about what anxiety is. Anxiety disorders are psychological disorders that are characterized by distressing, persistent anxiety or maladaptive behaviors that reduce anxiety. So maladaptive behaviors are these behaviors that someone might do to try to reduce this anxiety. So for example, if you have social anxiety, the maladaptive behavior may be that you never go out in public, that you try to stay to yourself and you don't go out very much. So, but anxiety is a part of life. If you've ever felt anxious when speaking in front of the class, peering down from a high ledge, or waiting to play in a big game, we all feel anxious at times, but occasionally feel enough anxiety to avoid even making contact or talking with someone. That can be shyness, we call it. Fortunately for most of us, our uneasiness is not intense and persistent. The tendency that it's when it's intense and persistent, this puts us at risk for anxiety disorders. So we're going to be talking about, and we got to put one more up there, we're going to be talking about these basic anxiety disorders through the course of this little lesson. We are going to be talking about generalized anxiety disorder, panic disorder, phobias, obsessive-compulsive disorder, or OCD, post-traumatic stress disorder. So these are the ones that we're going to try to cover during the course of this lesson. So first off, let's talk about generalized anxiety disorder. So Tom is a 27-year-old electrician. For the past 2 years, he's been bothered by dizziness, sweating palms, irregular heartbeat, and ringing in his ears. He feels on edge and sometimes finds himself shaking. Tom has been fairly successful at hiding his symptoms from his family and his coworkers, but sometimes he has to leave work. He allows himself few other social contacts than the people that I've just mentioned, very close network of people. Neither his family doctor nor his neurologist have been able to find any physical problem. So Tom's restless, unfocused, out of control, and agitated feelings suggest that he has generalized anxiety disorder. So the symptoms of this disorder are commonplace, but their persistence is not. People with this condition, they worry continually. They're often jittery, on edge, and sleep deprived. Concentration is difficult as attention switches from one worry to another worry. Their tension may leak out through furrowed brows, twitching eyelids, trembling, sweating, fidgeting. The person may not be able to identify, and really, therefore, it's really hard to relieve or avoid the tension's cause because they just don't know what's causing it. They're just on edge all the time and nervous. About 2/3 of the people that suffer with generalized anxiety disorder are women. So next, let's talk about panic disorder. In panic disorder, anxiety suddenly escalates into a terrifying panic attack, a minutes-long feeling of intense fear that something horrible is about to happen. This is usually accompanied by irregular heartbeat, chest pains, shortness of breath, choking, trembling, or dizziness may often accompany the fear. Those having, or even the people that observe a panic attack, often misread the symptoms as a heart attack or other serious ailment because the symptoms they're so similar to a actual heart attack. So we all live with fears. Some people with phobias are consumed by a persistent, irrational fear and avoidance of some object or situation. Let's have an example of a woman named Marilyn. She's an otherwise healthy and happy 28-year-old. She so fears thunderstorms that she feels anxious as soon as a weather forecast mentions possible storms later in the week. If her husband is away and a storm is forecast, she may stay with a close relative. During a storm, she hides from windows and buries her head to avoid seeing the lightning. Specific phobias, such as Marilyn's, typically focus on usually particular animals, insects, heights, blood, or enclosed places. These are common phobias. So we're going to talk about OCD, or Obsessive-Compulsive disorder. So as with generalized anxiety and phobia, we can see aspects of our own behavior in obsessive-compulsive disorder. Obsessive thoughts, this is the first part of the name, are the unwanted and so repetitive that they seem like they'll never go away. So the thoughts are the obsessive part. The compulsive part is what we're referring to the behavior. This is the compulsive behaviors are the responses to those thoughts. Okay, so the cleaning and cleaning and cleaning are the compulsive behaviors. All of us are at times obsessed with senseless or offensive thoughts that will not go away. Have you ever caught yourself behaving compulsively or perhaps rigidly checking, ordering, cleaning before guests arrive, or lining up books and pencils just so before you get into study? On a small scale, obsessive thoughts and compulsive behaviors are just part of everyday life. They cross the fine line between normality and disorder when they start to interfere with our everyday life, and they cause us distress. Checking to see if you lock the door is normal, but checking it 10 times is not. Washing your hands is normal, but washing them so often that your skin becomes raw is not. Normal rehearsals and fussy behaviors become a disorder when the obsessive thoughts are so haunting The compulsive ritual is so senselessly time-consuming that effective functioning in your average day-to-day normal life becomes impossible. So, as an Iraq soldier, Jesse saw the murder of children and women. It was just horrible for anyone to experience. After calling in a helicopter strike on one house where he had seen ammunition crates carried in, he heard the screams of children from within. "I didn't know there were kids there," he recalled. Back home in Texas, he suffered, he said, real bad flashbacks. Jesse is not alone. In one study of 103,000 veterans returning from Iraq and Afghanistan, about 25% were diagnosed with a psychological disorder. The most frequent diagnosis was post-traumatic stress disorder. So the typical symptoms include reoccurring haunting memories and nightmares, a numb feeling of social withdrawal, jumpy anxiety, and trouble sleeping. Many battle-scarred veterans have been diagnosed with PTSD, and survivors of accidents, disasters, and violent sexual assaults, including an estimated 2/3 of prostitutes, have also experienced these symptoms. The greater one's emotional distress during the trauma, the higher risk for the post-traumatic symptoms. So let's go through a few case studies, and you will need to answer these questions in the space provided next to this PowerPoint. Zelda, and also you need to decide which disorder that we have discussed that this is, whether it is PTSD, OCD, whether it is panic disorder, whether it is a phobia, or whether it's generalized anxiety disorder. Zelda is extremely concerned with cleanliness. In fact, before she retires at night, she goes through a cleaning ritual of her clothes and body that sometimes lasts for up to 2 hours. If she misses a step in the ritual or performs any part of it imperfectly, she starts the ritual all over again. Case study 2. Alex periodically suffers from extremely high levels of anxiety, but he cannot pinpoint the source or otherwise say why he is so anxious. He's terrified at times. His heart often races. He feels wobbly and has difficulty concentrating. As a child, Daniel saw the murder of several women and children as part of Saddam Hussein's policy of ethnic cleansing of the Kurdish people. As a teenager, he often wakes up from dreams where he's reliving the experience and can hear women and children screaming. This is case study number 3. Case study number 4. Sarah recalls feeling anxious about an assignment that she worked on, and all of a sudden she's feeling hot and as though she couldn't breathe. Her heart was racing, and she started to sweat and tremble and was sure she was going to faint. She complained that her fingers were feeling numb and tingly, and things seemed unreal. It was so bad that she wondered if she was dying and asked her husband to take her to the emergency room. But by the time she arrived, she felt normal again. Case study number 4. So how do learning and biology contribute to the feelings and thoughts found in anxiety? Anxiety is both a feeling and a thought, a doubt-laden appraisal of one's safety or social skill. How do these anxious feelings and thoughts arise? Sigmund Freud's psychoanalytic theory proposed that beginning in childhood, people repress certain impulses, ideas, and feelings. Now, this submerged mental energy sometimes, he thought, leaks out into odd symptoms like anxious hand-washing. Few of today's psychologists interpret anxiety this way. Most believe that 3 modern perspectives, conditioning, cognition, and biology, are more helpful. So let's first talk about the conditioning aspect. We are more likely to develop anxiety or PTSD when bad events happen unpredictably and uncontrollably. In experiments, researchers have shown how classical conditioning can link our fear responses to formerly neutral objects and events. You might remember little Albert. You've probably heard about him. He learned to fear furry objects that were paired with loud noises. The neutral objects were the furry objects, the rat. The object that he hated was the loud noise, and so he began to associate the rats with the loud noise, and so he was conditioned to fear the rats. By giving rats unpredictable electric shocks, researchers have created anxious animals. The rats, like the assault victims who report feeling anxious when returning to the scene of a crime, became uneasy. In the lab environment, the lab had become a cue for fear. Now, this kind of research helps explain how panic-prone people start to associate anxiety with certain places or cues. Why anxious or traumatized people are so attentive to possible threats. In one survey, 58% of those with social anxiety disorder said their disorder began after a traumatic event. So we also have two other conditioning processes. We have what is called generalization, and we have reinforcement. And they can magnify a single painful and frightening event into a full-blown phobia. Stimulus generalization occurs when a person experiences a fearful event and later develops a fear of similar events. So once phobias develop and generalize, they can be maintained by reinforcement. This is a part of operant conditioning. Anything that helps us avoid or escape from a feared situation reduces our anxiety. This feeling or relief can reinforce phobic behaviors. We learn some fears by observing others. For example, why do nearly all monkeys raised in the wild fear snakes, yet lab-raised monkeys do not? Surely most wild monkeys did not actually suffer snake bites. Do they learn their fear through observation? So oftentimes our interpretations and expectations also shape our reactions. Whether we panic in response to a creaky sound in an old house depends on whether we interpret that sound as wind or as a possible knife-wielding intruder. These misinterpretations can develop into irrational beliefs. So we learn fears by observation, and our interpretations and expectations can also shape our reactions. Now we get to the biology. Okay, so there is more to anxiety disorders, OCD, and PTSD than learning. Why will some of us develop lasting phobias or PTSD after suffering traumas? Why are some of us more vulnerable to learned fears? Why do we all learn some fears more easily than others? So this biological perspective will offer some insight. First off, genes matter. Among monkeys, fearfulness runs in families. A monkey reacts more strongly to stress if its close biological relatives have sensitive, high-strung temperaments. So some of us have genes that make us like orchids. We're fragile yet capable of beauty under favorable circumstances. And I stress favorable circumstances. Sometimes unfavorable circumstances will be really rough on us. Others of us are like dandelions, really hardy, and we're able to thrive in all kinds of circumstances. So some of us are genetically predisposed to anxiety, OCD, and PTSD. We also have the traumatic experience alters our brain. It paves new pathways. These fear pathways create easy inroads for more fearful experiences. So generalized anxiety disorder, panic attacks, PTSD, and OCD express themselves biologically as over-arousal of brain areas involved in impulse control and habitual behaviors as well. So our brain has a lot to do with how we interpret things and our anxiety levels. Also, one of the aspects of the biology is the natural selection. So no matter how fearful or fearless we are, we humans seem biologically prepared to fear the threats of our ancestors. Spiders and snakes, enclosed spaces, heights, storms, and darkness. In the distant past, those who did not fear these things were less likely to survive and leave descendants. So even in Britain, which has only one poisonous snake species, people often fear snakes. And we have these fears at a very young age. Preschool children detect snakes in a scene faster than they spot flowers, caterpillars, or frogs.